the hospital for blurry vision, admittedly very vague. Our wonderful faculty discussing today is Dr. Chavez. And Dr. Chavez did training in Peru, both a master's in research and epidemiology and medical school prior to coming to the University of Texas for residency and then coming and joining us here for fellowship in infectious disease and now staying on as faculty. And in that short amount of time has done now, this is the third CPC. So we're excited to have him back. Your initial thoughts?
Yeah, so the first thing that I said when I read your email was, is that it? Like, you're not giving me too much, really. But, you know, we have middle-aged male, history of tobacco and depression, so not very significant past medical history. You know, you can argue tobacco use, maybe 20-year history based on his age, so maybe some vascular risk factor there. Depression, maybe he's on some antidepressant medications that, you know, can cause some blurry vision, but I don't think that's going to be the reason for this CPC. And at least you gave me the information that presented to the hospital, you know, so this is not a patient that is presented to clinic. So maybe that gives us some hint that this is an acute presentation of blurry vision. But there's so many questions still on the table, like, is this blurry vision unilateral or bilateral? Are there any other associated eye symptoms like red eye or eye pain? Are there other systemic symptoms like headaches, any neurological deficits, you know, or systemic symptoms like fever, chills? And then also you're gonna go through, hopefully, through some of risk exposures, you know, where he had a recent trauma to the eye, any recent surgeries, or if he wears contact lenses. Also, you know, I would like to know, in a part of the physical exam as well, that may point towards anatomical disease. Now, regarding my approach to blurry vision, you know, I'm happy to improve this if anybody has a better approach than mine, but I approach it similar to vision loss. And I would say there's 4 categories that I've commonly used. One is refractory. That's very easy to rule out. You just use the pinhole test, and if the vision loss, the blurry vision improves, then, you know, this is refractory. But obviously, this is more clinic or issue in the clinic. The other 3 big buckets, I would say, is medical. So I include their medication side effects, but also vascular events like amaurosis fugax, you know, associated with giant cell arteritis. And the other 2 that may be worth mentioning are the ophthalmic and the neurological. So again, your physical exam should be able to point towards one of these buckets. So neurological, basically, you know, if the patient has some pupillary afferent defect, may point you to an optic nerve, and, you know, you can differentiate diagnosis based on where the lesion is, if it's pre-chiasm, optic chiasm, post-chiasm. And then with the ophthalmic, and that's the reason why I put the picture, because it's a very complex anatomy. I think that's one of the reasons why we have a specialty just for the eye. So, I mean, the residency was very confusing. You have a lot of ITs there in the eye. The way I like approaching the eye, at least infections of the eye, are more like from the diseases in the anatomy. So usually as a consultant, we are called with a condition, like the patient has keratitis, the patient has ophthalmitis or retinitis, and we can build a differential based on that. So we don't have any of that information yet. So one way to at least approach it is, okay, outer eye and inner eye. So the outer eye would be all the, you know, the blepharitis, the acrocystitis. You can also include their conjunctivitis. And then the inner eye, you have the keratitis to the cornea. You have all the uvea tract, so the uveitis. You have ophthalmitis, which includes the vitreous body, and then the retinitis as well. So, I mean, we can talk about the differential of each of those. I would say just briefly, I was trying to think what things, you know, you should definitely think if you're having a patient with blurry vision, at least from the ID perspective. I will include at least 3 or 4, definitely HSV and VCV. You know, they can cause keratitis, but they can also cause acute retinal necrosis, which can be very acute and can cause vision impairment. The other bucket, I would say STI. So that would include syphilis that can affect all the eye, and chlamydia and gonorrhea as well. So risk factors for STIs is important. The other 2, you know, want to consider also toxoplasma that can cause uveitis, retinitis as well. So that's something as well that can progress very quickly. And the last one depends where you at, but tuberculosis as well, something that we always keep in mind because some patients will receive steroids for some of these conditions and it can make TB worse. And with that, I think I'll stop.
Yes, let's get you some more information. That's very helpful. I will say the picture of the eye scares me every time. There's a lot packed in there. So to go through his presentation, 11 days prior to this current hospitalization, he went to an outside hospital clinic, just an urgent care. And at that time, he said he had 4 days of left-sided pink eye. He then noticed after that he was experiencing limited peripheral vision and anisocoria. So the very first thing he stated he noticed was that his pupils were different sizes. And now over that time period, the left eye has become more uncomfortable. Some pertinent negatives on that first visit to urgent care was no decreased visual acuity, no double vision, flashing lights, floaters, any eye movement issues, both in range of motion or pain with motion, no sensation of foreign body, discharge, itching, or photophobia. As you can see, the exam was abnormal and was notable for anisocoria, and at that time was referred to an outside retinal clinic for further evaluation and received a small systemic workup and was given antivirals and prednisone. Now, on presentation to the emergency department, came in and said, look, my eye is hurting more. The peripheral vision in my left eye is getting worse, and says that these antibiotics or antivirals are not working. And again, stated pupil constriction was noticed 2 weeks ago, and then came more of the peripheral vision loss, followed by more eye pain that was just described as kind of dull. There was, as far as systemic symptoms, possible weight loss, but didn't really know over what time period or how much. And then for systemic symptoms, at that time, denied any headaches, fevers, chills, body aches, or eye trauma. In terms of other details, so again, depression and anxiety is the only medical history. No surgical history, doesn't have any pertinent family history, does have 3 healthy adult children, no allergies. And this prednisone and the valacyclovir are both new medications that were started 11 days ago when he saw the physicians at the retinal clinic. And then the social history, heavy smoker and heavy alcohol use. And then occupation, he owns a flooring installation company. Going through the review of systems. So again, some weight loss. Also noticed over the last 2 months was having some night sweats as well. In terms of ear, nose, throat, subacute non-productive cough over that same time period. And then again, now describes this left-sided eye comfort and the vision decrease, particularly in the peripheral fields. Otherwise, largely negative. And so with that, that was a lot of information. What other additional thoughts do you have?
Can I have another week to think about it? So yeah, you give me more information that's very useful. So as of now, if you can please correct me, he has pink eye, he has some blurry vision. You mentioned he has different pupil sizes, some systemic symptoms like cough. You mentioned weight loss as well. Yep. And all this happened in a week, 4 days, you said?
So the vision stuff was all in the last 11 days, so just under 2 weeks. The night sweats and the weight loss, again, unable to quantify, doesn't quite know, but just knows he's been losing a little bit of weight and he has not been trying to. And all of that happened over the last 1 to 2 months.
Okay. So, I mean, we go just by the eye symptoms, just like, it's at least acute. And based on the information you're giving me, the pupil difference in size, that points more towards a nerve damage. So I would go to the bucket of neurological. And the question is where exactly within the whole optic nerve tract is the lesion or the problem. So again, because of the systemic symptoms as well, my mind is immediately going to something more systemically. Just briefly, if you can go back to his social history, I think you mentioned he works in construction. Is that right? So
yeah, he owns a flooring installation company.
So I mean that gives you some exposure to mold and some endemic causes. Does he have any sinus symptoms?
No, just a non-productive cough.
Okay. So yeah, so going to the differential of the neurological disorders, again, I mentioned a little bit about, prechiasm problems, optic chiasm and the posterior chiasm. So I would like to see, what is the visual field. He mentioned there was parts he could not see, that will definitely point towards where the lesion may be. If he has like a temporal defect, that we more like a optic chiasm lesion that would be meningiomas or pituitary adenomas, kind of lesions that can affect the chiasm. If it's posterior to the chiasm, usually you would have homonymous hemianopsia. So that will point towards more like a meningeal issues. You can have basilar meningitis. You don't mention any headaches or brain lesions that may cause that as well. And then prechiasm, I'm not sure if I'm pronouncing that correctly, but you would have more like ipsilateral visual defects, and it seemed like he had some pupillary defects. So I will curious about what exactly that defect was, if it was a relative afferent pupillary defect, meaning you light on one side and it doesn't constrict. That would point towards pathology in one single eye. So I don't think you've told me that. And the differential for that would include, optic neuritis and retinitis. And, I can go to that differential if you want me to as well. But that may include causes like, TB, CMV, and then compression lesions as well. So I mentioned sinusitis because sometimes sinus can invade the lower wall of the eye and can cause optic nerve damage. And sinusitis, could be many causes and many etiologies as well.
So still a very broad differential. I'm going to give you the physical exam, and I will tell you we will have more of a detailed eye exam in the future, but right now this is the internal medicine eye exam.
Mm-hmm.
And that's about the only thing that's abnormal. And essentially it's the eye looks weird.
Yeah, but you mentioned unresponsive to light, so that give you maybe a clue towards a afferent response, afferent pupillary defect.
Mm-hmm.
So again, definitely we're going to need some imaging, MRI, to look for sinuses and any lesions that may be compressing the eye. Regarding, etiologies, again, with those kind of findings, you're thinking about your retinitis or optic nerve neuritis. I would say the most common cause, I think, of neuroretinitis that can cause this would be cat scratch disease, but you didn't mention any exposure to cats. Then there ones would be TB. You're telling me cough, night sweats, so obviously that's something to consider. Ocular TB can present isolated from systemic TB, but usually, there's a primary focus in the lung, so an X-ray will be useful, as well as CT and exposures for TB that you probably have asked already. Yeah.
Yeah, so we can get into what sorts of diagnostics you may want next. And I will tell you the chest X-ray that was obtained in the ED was normal.
Okay. I mean, you can start with the initial labs. I don't think that's going to point me towards any diagnosis, but you have it there.
Yeah, so do you mind taking us through these labs? A lot of red on this slide. So nothing's abnormal.
That's fair.
And to take you through this, truly, I don't think I've ever seen this where every single lab, like not even one was red, but all of the labs were completely normal.
Yeah, so I expected. So I think, an eye exam, very good eye exam with fundoscopy would be very useful to kind of guide my ID workup, to be honest. Assuming I can start making assumptions about the eye exam, but if you see signs of retinitis, we're thinking about CMV, toxoplasma, I'll still, do a TB screen test. And then because of these mild systemic symptoms as well, I don't know how septic he looked. You can also consider doing blood culture. Sometimes endogenous ophthalmitis as well can cause eye issues, but this patient would have eye pain, floaters, more abnormalities maybe. So I don't know. Initial imaging, I guess. I mean, I would probably do imaging, ID evaluation all together.
Yeah. Any specific imaging off the bat?
So you say X-ray is normal. So if he is having cough with the night sweats and the TB and the differential, I'll probably do a CT of the chest as well.
Yeah, so we can start with that. I'm going to pass it over first. We'll go through the CT of the chest with our friends from radiology.
How's it going? I'm Josh with neuroradiology, but I'm going to talk about a chest. So, he had a CT of his chest and his abdomen and his pelvis because he came to the ED. So there was an indeterminate lesion in the kidney that just needed further evaluation, but didn't look suspicious, particularly suspicious, but it just measured a little bit more density than a typical cyst. In the lungs, in the right lower lobe, he has this kind of pleural base, subpleural, measured about 1.6 centimeter nodule. well-defined borders, no ground glass opacities anywhere, no additional nodules, no enlarged mediastinal nodes, no hilar nodes, and then, like I said, no other acute findings in the abdomen or pelvis. So from a radiology standpoint, this would be probably classified as an incidental nodule, and based on size criteria, that would need a follow-up in 3 months to assess stability,
Gotcha.
but nothing suspicious about it.
Yeah, thank you.
Yep.
Yeah, or a non-ID differential, would be sarcoidosis and Wegener's disease as well. It can affect the eye, but it seems like that also
so
brings
these-
it very low in differential.
And just in case these are a little bit helpful, so these are the two reads. So we did have a CT facial bones that really noted left eyelid swelling. The eye had been touched enough times that they did not think this was preseptal cellulitis. And so that was largely not super helpful. And then we just went over the CT chest, abdomen, pelvis. So do you feel like the CT chest, abdomen was helpful at all, or?
I mean, yeah, it seems like, without any hilar lymph nodes or any more parenchymal pathology, at least pulmonary TV seems very unlikely based on the characteristics of that nodule.
Would you like a more detailed eye exam?
Yes, please.
Do you like my pun? I need help. Went through a lot of different variations of that one. All right, so this is our ophthalmology consultant. So just to take you through briefly, again, it's seen a number of eye doctors to this point. The initial evaluation actually at the outside clinics was documented as a concern for hemorrhagic vasculitis, and that was part of why they started the patient on steroids. They were obviously also concerned for some of the things you mentioned, so things like HSV and VZV, and that was the reason that the patient was getting the valacyclovir. These initial labs that were done prior to arrival to the hospital were notable specifically for serum IgG CMV positive. I did want to ask, does that help you at all? Do we see positive serum IgG commonly?
Yeah, like 50% of us has been exposed of CMV at some point of our life. So IgG would not be very helpful in this circumstance.
Okay. And this is their description of their eye exam. And so a little bit different than our eye exam. They noted 1 to 2 plus injection, 3 plus suspended cell with fibrin at the pupil and prominent iris vessels. And then they noted these subretinal yellow deposits. And there are pictures of them there. And so the concern was panuveitis, and they still had a very broad differential, but did end up performing a vitreous tap.
Yeah, so thank you for sharing that. So, I mean, I'm still curious about where this is specifically to the eye or more a systemic symptom based on your or symptoms that you mentioned. But, it seems like the anatomical problem is panuveitis, and, the choroid, which is part of the uvea tract, is very vascularized. So also systemic infections can easily get to the choroid and cause choroiditis and uveitis and retinitis. I'm trying to look at the picture and see if something comes to mind. Classically for toxoplasma, there's described fog in the headlight. So it's kind of like cloudy from the retinitis, and there's a headlight very clear. It doesn't look like that. Then or CMV retinitis, it's very also kind of classical findings. Ophthalmologists should be able to tell you if it looks like CMV retinitis. And CMV retinitis, we usually see it in patients that are immunocompromised, especially patients with HIV. It's less common in patient transplant. As of now, there's no signs of that this patient is immunosuppressed. So CMV retinitis will be also less in my differential, but we still should do a CMV PCR in the blood. And then more bacterial and parasites. So, bacterial, many things can go into the eye and cause either endophthalmitis or uveitis. So, like I said, the choroid is very vascularized, so anything can get there. The patient has, for example, IV drug use. You can have candida infection. You can have Staph aureus, Klebsiella, Haemophilus. Many bacteria can cause what we're seeing here. So, asking very well those questions where the patient has had IV drug use, or things, without trauma, I wouldn't be thinking about, cardia or NTMs. You didn't mention any other risk factors for TB, right?
Yeah, no travel, no IV drug use.
Okay. So, I mean, yeah, the Beatrice tab, we'll send it for culture for bacterial, fungal cultures as well, and they'll give us some information. Whether an MRI will help the differential. I think you mentioned some eye redness, and they mentioned some preseptal cellulitis as well. So whether there's some bone involvement as well, would be curious to know, but the CT didn't show it.
Okay. So which would you like next? More of a serologic ID workup, imaging? What would you be sending next?
And then I forgot to mention fungal infections as well. So, histoblast. So there's been case reports that, gone to the eye, but given his exposure as well, worth checking. I mean, obviously I'm an ID, so I will want to go to ID. But I mean, I think the culture may give us information. Yeah. So yeah, I mentioned about the immune status where the patient is immunocompromised. So I forgot to mention IV, but that's something should be ruled out from the beginning. Syphilis, non-reactive. I mean, it seems like everything is negative there. Yeah, so I think the cultures may give us the answer, really. I don't know if you collected blood cultures, if the patient, how did he progress during his hospitalization? Was he septic? Did he have fevers?
So do you want to see the vitreous cultures? Is that what you're wondering?
I mean, I don't know, it seems like that's not going to give us the answer. So yeah, you can share it. Yeah. Okay. Interesting. So I don't know if they send also for mycobacterial cultures, but that's a very extensive workup that seems like it was negative. So what can you tell me extra from the patient? How is he doing so far?
Yeah, so at this point, what they're doing is they're giving him steroids. They're also doing intravitreal injections. The vision's not changing, still has eye pain and swelling, largely related to getting his eye dilated and manipulated each day. They're doing daily fundoscopic exams. No neurochecks can be performed because his eye is constantly big. And so they're largely waiting for these exam findings in these cultures, which were negative. And so most of the serologic studies here were all negative. And I think you did allude to wanting more imaging. So what other imaging would you consider needing in this patient?
I mean, given the pupillary defect, the MRI may be helpful to see what's going on with the optic nerve.
Okay. So we'll go through the brain MRI.
Okay, so we've got a couple areas of interest here. So this first area we're looking at is kind of in the left frontal lobe. And so if we work through the images kind of top left and then clockwise, so we've got a diffusion weighted and ADC sequence. And what we see is a small focus of restricted diffusion that has hypo-intense signal in ADC. So it's a true area of restricted diffusion. Here in the center of what we see on the flare is this edema. Oops. Over there, I can see it. Okay. So small dot, restricted diffusion surrounding edema in the left frontal lobe. And then on our postcons, we have this kind of complete ring enhancing lesion without any enhancement in the center. On the same MRI, when we look at the orbit, we can see a couple different things. We can see there's some proptosis. We can see some overlying swelling. We see some enhancement of both kind of the preseptal soft tissues as well as the lacrimal gland. Not really much optic nerve enhancement. The extraocular muscles look pretty symmetric to the other side, but we do see a little bit of edema in this kind of intraconal fat. And then we have thickening and flare hyperintensity of kind of that entire globe. This anterior aspect that we have here, where we essentially have no signal, is air that they've injected with their kind of numerous vitrectomies. So sometimes you see air, sometimes if they inject silicone, you can see silicone. They have kind of a similar appearance. The air has a little bit more kind of fuzziness around the edges, but in this case, they weren't injecting silicone. So we've just got some air in the orbit. What you can see here, and you don't appreciate it because I can't really scroll through, but we have sort of this elevated membrane, and over here, there would be another one kind of like this. And so it would look, sorry. So right here, And then there's another one over here if we're able to scroll up and down. And so it makes kind of this hourglass appearance. So that's kind of typical for a retinal detachment. So there's a detached retina. And then we also have this little kind of nodular focus of enhancement, kind of along the back wall of the globe. And this was T1 hypointense on the pre-imaging. So if we take these two findings in conjunction and we're just kind of looking at them in a vacuum, let's pretend like I'm not looking at any of the clinical and kind of trying to prioritize my differential. If we go back to this, the differential on this, abscess, Mets, primary lesion, toxo can also be ring enhancing. I wouldn't favor you can have enhancement and restricted diffusion in stroke. I wouldn't favor it because of the shape and distribution. Usually you don't get ring enhancement in stroke. You get sort of like gyral enhancement. So kind of a broad differential. And then with these eye findings, you know, one, you'd be worried about trauma or some kind of foreign body. You'd be worried about infection, but you also have to worry about tumor because we have this enhancing nodule, and it actually also restricted diffusion. And so you worry about something hypercellular. So having those in both places, one thing you always think about is melanoma. So melanoma can met to the eyeball, and it's kind of T1 hypointense because of the melanin content. So that would be, again, in a vacuum, things to think about.
Would you say that retinal detachment is this because there's like an abscess underneath, or just like?
It's possible.
Okay.
I mean, in the absence of any other kind of trauma, you could assume that it's related to either if there's a mass underneath it or if there's infection going on. If I had to come down, I would probably come down more towards infection just because we have some of the surrounding inflammation and kind of inflammation in the intraconal fat. So that sort of points me away from a lesion, but either one is possible.
Yeah, thank you. So, I mean, what I would do first, you know, is also talk to micro to see what we have sent so far, you know, talk about our differential, if there's any more tests that we can send, like PCRs or sequences from the current vitreous fluids that we have. With that information from the brain, you know, we're thinking about more systemic problem that may have, you know, metastasized to the brain and the eye. So I didn't mention cancer, but intraocular lymphoma, you know, it's a thing. But I think with this acute presentation, would be unlikely in this 48-year-old male. Then regarding abscess and bacterial, so when we talk about eye and brain, you know, there's a few pathogens that come to mind. You know, one is nocardia that can affect, you know, lungs, brain, and eye. Then you have also the endemic mycosis as well. So yeah, I would double check that you send all the right tests, including histoplasma, urine antigen. And then we go into the weird bacteria as well. So rapid growing mycobacteria as well could potentially affect the eye, but not necessarily with that high frequency, the brain. And then all the bacterial, you know, we're still talking about, you know, even staph aureus with ophthalmitis and brain abscess, you know, Klebsiella gram negative. So you didn't show me, or blood cultures are negative. So yeah.
Yeah, great. So when a patient's infectious eval is this negative serologically, and obviously we have very impressive imaging findings, very impressive physical exam, and we have those new imaging findings with the brain lesion, how would you pursue further working that up from an infectious perspective?
So, obviously, you know, one of the answers is going to be brain biopsy, but does he have any neuro deficits at all?
Any what?
Any neuro deficits?
No.
No.
No focal deficit
No headaches,
peripherally.
Okay. Yeah, I mean, obviously, we cannot get a diagnosis based on the eye, and if it's progressing, you know, brain biopsy maybe pursue to make a diagnosis.
Yeah, thank you. So that is essentially what happened. So we'll go through the brain biopsy in a second, but just to describe briefly to that point, there was a large discussion that happened because of the lesion that was in the lung as well as to which lesion to biopsy. And at the time, they weren't convinced that they were going to, one, be able to obtain an adequate sample from the lung. They were going to have to do a wedge resection because of the location. And two, it was unclear whether or not these two things were related. And so neurosurgery did take this patient for a brain biopsy. And we do have a friend from pathology to take you through those findings.
All right, so my name's Brendan. I'm one of the Neuropath Fellows, and I'll just take us through the microscopic findings from the brain biopsy. But first, before I do that, so a lot of the time when neurosurgery takes a biopsy or does a resection, they'll send a frozen section so they can get a better idea of what they're dealing with while they're in the operating room. They sent a frozen section in this case, and the findings are consistent with what we saw on permanent sections. So with this biopsy here on low power, we can see this focus right here of inflammation. And then surrounding it, the brain, it doesn't look happy. I'll show it at higher power, but the brain is starting to get necrotic with some reactive vascular changes and overall reactive brain tissue as well. And then at higher power, you can see that there are just abundant neutrophils all throughout the brain. There are perivascular aggregates here. They're adjacent to this vessel. This isn't something we would expect to see normally. And I'll say right off the bat that this isn't something we would necessarily expect to see in a malignant process in and of itself. It might be secondary to changes caused by the tumor, but it wouldn't be primary. And then we did a couple of special stains to get a better idea of what we are looking at. The two most contributory ones were a gram stain, which shows a few positive organisms that are probably pretty hard to see. The stain doesn't always photograph very well, but then we did a GMS, which is a modified silver stain, and we can see all of these thin branching filamentous organisms throughout the lesion. One thing to note is that when we do see organisms on a biopsy, we can't speciate them. We leave that to our colleagues in microbiology, but if we have a previously reported culture that says it's positive for staph, Pseudomonas, any species, we will say that it's consistent with whatever the species was. Would you like me to present our diagnosis or stuff here? Okay. So our overall diagnosis was an abscess with numerous thin multi-branching filamentous organisms, suggestive of a nocardia species. And of note, on our frozen section, we essentially said the same thing.
So in light of those findings,
Yeah, I mean, everything fits the picture for nocardia, the filamentous organisms, seeing the pathology, the brain lesion, the panuveitis. I've never seen nocardia affecting the eye that quickly, but I'm sure it's been described. So yeah, you'll see brain abscess, panuveitis, secondary to nocardia species.
and I'm curious, from your perspective, in terms of finding nocardia in this patient without seemingly obvious risk factors, how do you reconcile that? And then what are the next steps you would potentially be taking now, considering that he may have a nocardia infection?
Yeah, that's a good point. So we do see nocardia most frequently in patients that are immunocompromised, but we also see it in patients that are immunocompetent. Within the immunocompetent, we see patients with diabetes, all patients, their immune systems are already affected. So they may have some level of immunosuppression, but we do also see it in patients with immunocompetence without real risk factors. And the question whether they have the underlying any gene mutations, hard to know. But we do have a clinic of immunology. I would definitely send the patient there and do more tests. Yeah, I mean, you can always check, CD4 count specifically. Sometimes they have isolated CD4 count cytopenias or low cells.
Yeah.
So my thoughts right now. Yeah.
So you did nail it as far as the diagnosis. You identified both endophthalmitis and the nocardia. And so we'll take you through the hospital course to date now. So after they identified the nocardia, and they did actually, so they committed to that as the diagnosis and then started to treat it with antibiotics, initially with Bactrim and imipenem, and then they were able to actually send it for specifically for the speciation and to get susceptibilities. And the antibiotics were switched, but ended up receiving 17 total months of therapy before showing a resolution in the MRI lesion. Interestingly, over that time period was that the lung nodule also did resolve. It was never sampled, but sort of went to lung nodule clinic and it no longer was there. And it was still unclear as to whether or not it existed or was related at all, but I think in light of those findings, people started feeling like that may have been one of the primary lesions. And yes, as you said, so the question remained why this patient was predisposed to nocardia and was sent to allergy and immunology and had a number of labs sent, including labs to the NIH. And the one that came back positive was antibodies to GM-CSF. And so just to go through that a little bit more. So GM-CSF antibodies actually tend to be more common than we think, but in particular in patients who suffer from nocardia, crypto, or pulmonary alveolar proteinosis. So it's critical in the innate immune response. And it turns out our innate immune response, it doesn't actually take care of nocardia, it more so keeps it at bay until the humoral response can be achieved. And so patients can have a more disseminated infection. And in the context of the pulmonary alveolar proteinosis, the macrophages that are in the lung depend on this GM-CSF to help break down surfactant. And that's what ends up building up in those patients within their lungs. And so that is what they ended up identifying or considering the etiology of this. And I think we do have, this is just the picture of the lung after they had repeated it. Oh, that's the picture of the lung. Any other last thoughts?
No, very interesting case. Yeah, I've read about those antibodies, but I never seen a case of it. So it's very interesting. Yeah.
Well, thank you very much.
Thank you. That's,